Morning or this afternoon, this evening. My name is Todd Tuttle, and I'm a surgical oncologist at the University of Minnesota, and I have a special interest in global breast cancer. I have been working with our partners in Honduras and Mongolia and Uganda for many years, and I've also had the privilege of working with the Global Breast Cancer Initiative with our guest speaker today, Dr. Ben Anderson. My colleague, Dr. Morgan, and I decided to start this monthly virtual global breast cancer seminar to provide multidisciplinary learning opportunities for physicians who are treating breast cancer globally, especially in resource limited settings. And many of our partners have asked for more intensive breast cancer educational opportunities, and we hope that this seminar will help meet this request. Additionally, we also wanted to create a global community of breast cancer physicians who can meet and collaborate. And I don't know how that's going to look out or play out in the upcoming months, but we certainly hope that we're able to kind of work better as a community and address similar and common problems. We're going to meet on the first Tuesday each month at the same time. We'll again ask you to register for each seminar on the website, and then about a week before each seminar, we'll post selected readings chosen by our speakers in preparation for this seminar. And we're going to cover a wide range of topics, including high risk breast cancer, surgical treatment, reconstruction, radiation, lymph node management, pathology, physical therapy, how to manage triple negative breast cancers, how to manage HER2 positive breast cancers over the next course of the year. Over the course of the year, I'll introduce my colleague, Dr. Jennifer Morgan.
Hi, everyone. It's a pleasure to be here. I'm a medical oncologist at University of Minnesota, and I've kind of worked in breast cancer and cancer care in the East African region, and currently work with the AMPATH partnership in Western Kenya. It's a pleasure to be here, and I'm excited to get this going.
Wonderful. Hey, Jennifer, you want to introduce our speaker today?
I think Jennifer's muted, but perhaps I can just go ahead and do that myself. Todd, is that okay? All right.
Wonderful.
Yeah.
So I'm Dr. Ben Anderson. I'm professor emeritus at the University of Washington. And in addition to my breast surgical practice at UW for 26 years, I started working in global health in the late 1990s and to focus on breast cancer in low and middle income countries. And so what I'd like to do, if I could, is go ahead and get started. Todd, can you confirm that you're seeing the slides correctly?
They're on.
Okay, great. So I'm so sorry because this is about an hour talk, and I'll try to move along with our little delayed start here. But I wanted to begin by pointing out that what this work has always been about is equity. And I must say that when we first started talking about equity in women's health, I was not anticipating some of the recent changes where equity could be actually turned into a term that is not desirable. But I think that actually the work we're doing in oncology and women's health is tremendously important for equity, and that is the fundamental framework. Our original work was with the Breast Health Global Initiative, BHGI, at the Fred Hutchinson Cancer Center. We did our work with the support of Susan G. Komen and industry to run our global summits. And I also want to mention the funding that came to City Cancer Challenge and WHO. Industry collectively provided funding so that we could do work on the Global Breast Cancer Initiative, which is WHO's project for addressing breast cancer in low and middle income countries. Breast cancer is the most common cancer among women worldwide. It is the most likely reason a woman will die of cancer. There are more disability-adjusted life years lost to breast cancer than any other malignancy. And the majority of cases and deaths are already occurring in low and middle income countries today. And that is a huge gap that we need to consider. By 2040, this gap is going to be even wider, with 60% of the projected 3 million cases and 70% of the 1 million deaths to be in low and middle income countries. We see this broad range of survival, 90% 5-year survival in the US and Western Europe, but 66% in India and 40% in South Africa. So there's a clear statement of disparity and lack of equity. The question, on the other hand, is what can we do to apply this and take what we've learned to take what has worked in high-income countries and use them in limited resource settings. So here you see the incidence of age-adjusted of breast cancer globally, which lends the impression that breast cancer is really just a problem in the high-income countries. That's because the absolute numbers are higher based on early detection and screening. But if you ask the question, what is the most common cancer among women in countries? 86% of countries, breast cancer is number one. And when we look at mortality, while the mortality statistics are the most problematic south of the equator, if we ask where is breast cancer, it is the number one or number two cause of cancer-related deaths in 95% of countries. And this is relevant because it means that no Ministry of Health can overlook breast cancer if they want to address breast cancer as a public health issue in their country. Breast cancer is just too big. But when we started doing this work in the late 1990s, people assumed that we needed to repeat what it was that we had done in high-income settings, and in the same way that one might say, oh, well, we need to solve cervical cancer with Pap smears, because that's what was done first. We really need to rethink this idea and understanding of early detection. So screening began in the early 1980s because of the HIP trials in New York showing survival benefit. And it was about 9 years later that we started to see a drop in breast cancer mortality. And it tended to be assumed that, well, it must be the mammography that's doing this, since this was this major change. And now we have these randomized trials that showed survival benefit to mammographic screening, almost without exception. But the question of, was it the mammography that was doing it, or was it the stage shifting that was doing it, that has not been entirely clear. We do have adequate evidence that ages 50 to 74, mammographic screening improves survival. We have borderline data in the 40s. The strongest data is 45 to 50, but actually the role of mammography for women under age 45 is really unclear, especially with the high false positive rates that are associated with intensive mammographic screening. But we have to think a little more broadly. And while early detection is essential, especially in countries where the majority of cancers are stage 3 and 4 at diagnosis, we have to remember that this early detection approach only works when it is followed by effective treatment. Just screening for cancers does not shift survival curves. So we have to think systematically. Interestingly, the Canadian trials were the one set of trials that did not show mortality benefit. And this was highly debated. The thinking of what's wrong with the Canadians, that they were not successful in showing mortality benefit. But when you actually look at their data and you see that in their control arm, where they did clinical screening without mammography being the entrance, the tumor sizes were about 2 centimeters. So rather than asking the question, is it the mammogram, the question might be, how do we get to this place where clinical detection can find cancers at that 2 centimeter range, which is a very reasonable cutoff point. If the problem that we had in the late 90s was that our guidelines, NCCN, ASCO, ESMO, they didn't tell us what to do in the limited resource settings. So we began to ask the question, what adaptations do you need to improve when resources some are available, but others are not? And of course, what then are the healthcare system characterizations that then we can bank on for improving outcome. And we have to ask the question, are meaningful improvements even possible? When we started doing this work in the late 90s and early 2000s, most thought, no, you really can't do this in the most limited resource settings. But that's why we need a health systems perspective in how we're going to address these issues. Ideally, we would prevent breast cancer. We'd ideally prevent all cancers. This is why tobacco control is the low-hanging fruit of cancer control. And what we know is that weight control, avoidance of obesity, alcohol, physical inactivity, there are risk factors that are modifiable with behavior changes. But if you ask the question, say everyone does all these things that we're supposed to do, and we're healthy, and we eat the right diet, and we're not obese, and we exercise, and we stop drinking, what fraction of cancers would be addressed? And the answer is perhaps 1 in 5. So that would be an improvement, but it means the great majority of cancers are going to occur even with our best primary prevention efforts. And therefore, if we cannot prevent cancers, at least not prevent all of them, then the question is, how do we build systems that goes through those steps of early detection, prompt diagnosis, and treatment to completion? The health systems question is, what supports this and what are necessary? When we started doing this work at WHO, I was at WHO from 2020 to 2023 when we launched the Global Breast Cancer Initiative. And we did this initial analysis to ask what features of health systems are associated with improved breast cancer outcomes. And there are 2 factors that are linked in multivariate analysis. One is payment. What is the degree of universal health coverage? We need to provide financing for this because cancer care is too expensive to pay out of pocket. And access. So it's funding and access, the number of public cancer centers. So funding and access are really fundamental to what it is that we do. We subsequently looked at, this is an example of 21 Asian countries, and you can see that there's a good association between earlier detection as measured on the x-axis by stage of diagnosis and universal health coverage, better coverage, earlier detection, and that early detection is associated with improved 5-year survival. So this makes sense in our systems to be addressing this. And if we don't have ways of providing access and funding, it is debatable whether we can make progress. But isn't this interesting? Here you see the red bars. These are countries in Asia sorted by breast cancer mortality rates. And you can see incidence goes up and down depending on detection techniques. And so just finding more cancers may not necessarily directly translate to mortality. So we have to think beyond this. But again, back to that question of resource limitations. This is where we started doing our work with the Breast Health Global Initiative and established these principles of resource stratified guidelines. Our very first summit was in Seattle in 2002, where we laid out disparities, and each summit was based upon the NCCN methodology of bringing together experts, identifying evidence, and generating guidelines and approaches. But after that very first summit, now 23 years ago, we received this critique, which said, gosh, some countries are so poor that breast cancer is just not really a problem for them relative to the other healthcare issues, which begs the question, so what makes you ready to do breast cancer? We went to Ghana, West Africa in 2004 in order to address that first question. And I must say that when we did this, at that time, the thinking was breast cancer in Africa, cancer in Africa, we were really critiqued. And because the rationale was, well, you can't do all of the things that we do in high-income countries. But when we went to Komfa Enoche Teaching Hospital in Kumasi, and we went to their breast clinic back in 2004, it gave us some insights into the nature of the cancers that were found. This is a picture of the earliest breast cancer that I saw back in 2004. And as you can see from the diagram, it was a palpable 10-centimeter mass. And none of us would consider this to be early detection, but this is the most common cancer presentation. They did, in fact, have a multidisciplinary clinic where they reviewed cases. But the issue, of course, was that these late stage presentations were so common. Here we have a photograph. This is from Kenya, but these were typical cancers being seen at the center. And so when we talk about mammographic screening, this photograph makes it kind of apparent. Why would you need a mammogram if you can see the cancer from across the room? Mammograms is not an entry point. Mammograms is a subsequent evolution where we can address these clinically detected cancers first. We saw advanced stage at diagnosis. We found that patients were receiving mastectomy, but no systemic therapy, which with advanced stage cancer is predictable to have poor outcome. They had limited resources, like one pathologist for that 1,000-bed hospital, and pathology reports would take 4 to 6 months to generate. These observations led to our initial development of resource stratification, the idea being that there's some resources that must be in place. We have to be able to operate on cancers. We need fundamental systemic therapy in order to improve on outcomes. And we can lay out these standard resources in ways to design a building block approach. These were the guidelines that we published back in 2008 after subsequent review, and it lays out health systems, early detection, diagnosis, and treatment by stage, standard therapies stratified. And so it can provide guidance on where do I go to build my system. It's important to understand that resource stratification is not certifying substandard care. It's defining a pathway for progression. And that is how we have to think this through about where do our evidence show that the interventions that we need to do and that you will be working on in the programs that the University of Minnesota is driving with breast surgery and global breast cancer. We need to be able to adapt to existing resources and that these are models that we can use. And that resource stratification was subsequently looked at by WHO, and in 2017, they issued this cancer resolution in which they asserted that resource stratified guidance was a key principle for the work to be done. And this is when WHO really transitioned into therapy, not just prevention and supportive palliative care. But what about the paradigms for change? We have to think differently, and I'm just going to provide a brief example, which was actually the entrance point for a group of us going into global health. This was in Ukraine back in the late 90s. That time, no one talked much about Ukraine, but it was an area where Congress wanted to create links with Ukraine because of their nuclear weaponry. We had this program to which we were consultants with funding to develop breast clinics in Ukraine. And what we saw was that they instituted screening. They did not have mammographic screening that was adequate, and 18,000 women were screened by clinical breast exam. And you can see that with this, that there was a rapid increase in stage 1 and decrease in stage 4, which was really exciting. And it showed that early detection was working. But this slide is the key point. The program went until 2000, 1999 to 2000. But what this shows is that they made progress and continue to make progress in diagnosis and treatment even after the program ended. So one of the key measures of is a program working is does it work after we go away, after we're done? And I would say that these are the sorts of metrics that we want to be thinking about. But how do we design this framework? How do we think this through? This was the hub of the work that we did at the World Health Organization over the 3 years of launching the Global Breast Cancer Initiative, and it is based on the patient pathway. The GBCI framework was published in March of 2023, and the goal here is to reduce breast cancer mortality by 2.5% per year, because that would avoid 2.5 million lives lost to breast cancer over a 20-year period. Here you see mortality curves for 10 countries, 9 of which are high income that had that significant reduction in breast cancer mortality. Those curves between 1990 and 2020, that drop was between 2 and 4% per year. So 2.5% is not fictitious or artificial. It's a real number that we did in the 90s with tools that we would consider standard today. The question is, how do we translate this to low and middle income country settings that had not yet seen that mortality survival improvement? And our rationale was to do what we did clinically in high income countries in 3 phases. We first have to find the cancers when they're earlier. We have to prove that they're cancers in a reasonable period of time, and we have to provide treatment. This is the basis of what we've done, and it's the basis of what needs to be set up. We recognized that there were certain key performance indicators that corresponded to the 3 pillars, and we'll talk about those indicators because if we don't measure outcome, we will never know if we are able to make improvements in our outcomes. So in that first pillar, that health promotion for early detection, that question is, how do we get cancers where the majority are not stage 3 or 4? And there are 2 ways that patients enter the system. Yes, we can do mammographic screening, and that is what we do in high-income countries. But our evidence supports the use of mammography for ages 45 to 74. It does not provide guidance about what to do with the younger women where screening has not been shown to be the effective strategy. And so that finding cancers early, clinical detection, is a fundamental key. And the target for that is for at least 60% of invasive cancers to be stage 1 or 2 at diagnosis. Where did we get that number? Well, in that same analysis where we were looking at health systems limitations, we looked at what were the features of those countries that achieved the mortality reduction versus those that did not. We identified 35 countries where we had adequate data. And what we found was that every country that has successfully reduced mortality in breast cancer, age-adjusted, had at least 60% of the invasive cancers being stage 1 or 2. So instead of arguing, do we do mammography, do we not do mammography, the question is now different. The question is, how do we get across that threshold of 60%? And whether it be through clinical means or radiographic means, that's the important question. And there are ways in which we can do this. So if we're somehow able to get the women in with these earlier stage disease through public education, through professional education, and building our systems, we still have to distinguish who has cancer and who does not. And so in the second pillar, prompt diagnosis, how do we prove who has cancer and who does not in a reasonable period of time? That is this fundamental strategy. And we remember that when 10 women come in with a palpable lump, 1 will have cancer and 9 will have benign findings. And if you can't complete that diagnostic workup in a prompt period of time, you will not be able to achieve those necessary outcomes. Where did that 2 months come from? This analysis, it was a systematic review from 1999 in which they looked at delay and 5-year survival. And they found that if delay was longer than 3 months, survival at 5 years was 12% lower. If they could confine it to 3 to 6 months, it was now 7%. So the rationale that we are using here is to say that we need to start treatment within 3 months, as that's when mortality curves start to worsen. And if we can prove that it's cancer within 2 months, that gives us a month to initiate therapy. These are guidelines that ministries can look at their data and see, are we achieving it or not? We have to develop resource appropriate health systems strengthening. The International Atomic Energy Agency has started an excellent program in breast cancer screening and diagnosis. But thinking of it not just from that narrow mammographic screening perspective, but from the broad diagnostic workup, linking clinical assessment and imaging. Dr. Miriam Michael is in the lower right there, and she's been leading these major efforts. And these are the sorts of things that each of us can entertain into our activities. We recognize that health professional training, The diagnostic services and patient navigation through these systems were essential. And following the launching of the Global Breast Cancer Initiative, I worked with the City Cancer Challenge to develop breast cancer action plans specific to cities. And we now have methodology for asking, how do we adapt resource limitations to address diagnostics in these settings? Treatment to completion is the third pillar. We often talk about treatment and we'll use indicators like, did she start chemotherapy? But it's really important to remember that it's not the first dose of chemotherapy that matters, it's the last dose. Did they complete their treatment in order to make it? And did we have the surgery, radiotherapy, drug therapy in place so that that treatment to completion were possible? We recognize that supportive services are really essential, that for both for quality of life, but also just getting through the therapies. So antiemetics are essential if patients are going to continue on their chemotherapy, for example. So the messaging that we have is that supportive services are not optional, they are required. And we should never forget that it is survivors, it's advocates that drive many of the political changes that are needed in order to address these outcomes. So survivorship and patient-centric care is fundamental to the work that we're doing. If we then ask, well, what do we do and what are our targets for treatment, this third pillar? We identified 80% as being the goal for at least 80% of patients who start treatment to complete it by standard definitions. That's using multidisciplinary care with our multimodality therapies adapted to the patient's specific requirements, that multidisciplinary management that we do in our clinics, patient navigation. How do we get the patient through the system and how do we monitor this? If we don't monitor our outcomes, and that is, you need to think of that at the beginning, not later, to sort out what is that data that I really need to have in place. But again, we think comprehensively, and that includes after the treatment of conclusion of treatment for non-metastatic cancer. The woman returns to her community. Financial toxicity is a frequent problem in low and middle income countries, but we can establish follow-up care, leveraging primary care services, and survivorship and palliative care to support women through these processes. These are well laid out in our work in our publications. But what's the basis of that 80%? Why is this abandonment question such an issue? Here you see graphs that were created by the International Agency for Research on Cancer, IARC, and this was data collection done in 5 sub-Saharan African countries. And while it's a little tricky to look at the diagram, the summary is in the lower right-hand corner here, and the orange area under the curve, those are the patients that started treatment within 3 months and took it all the way to completion. And what you can see is that only about 50% of the African patients actually made it all the way through treatment. It is predictable that they will not see the favorable outcomes that are needed. And that's why treatment to completion is so fundamental, and yet it's something we don't talk very much about measuring. And yet it's this key driver. If you look at the IARC data, the blue curves were the actual 3-year survival. But what they did was they projected based upon the 3 pillars: improved treatment, downstaging of disease, and increased access by reducing social inequity. And what you can see is if you address those 3 key performance indicators, the survival curves will predictably rise significantly up to levels that are much more acceptable by standard terms. The point of this is the 3 pillars work and are a good framework and guideline for where we go. As we said, though, we have to monitor our outcomes and we have to develop measurement strategies that are reasonable. And that's because using those 3 key performance indicators, we can identify using fishbone analysis where the gaps may be in our system. So WHO in its health systems analysis talks about 6 building blocks for health systems: health workforce, health facilities, service delivery on the one side, and then processes, referral, medical product availability, and information management. And we can do this fishbone analysis that helps us in a specific environment sort out, where's my problem? And gosh, we would do the same thing in our clinic. If we have delays in getting patients through, we would look to root cause analysis. What's happening that we have issues? So by using fishbone analysis, we can do these types of analyses. We recently went back to Ghana together with City Cancer Challenge and WHO. This was a meeting held in Kumasi at the end of 2024. And what we did was an analysis of their systems. One of the pieces that was so interesting is when you look at those are the facilities that deliver healthcare and cancer care in the city of Kumasi. And what it illustrates is there was no single center that could do everything within the system. You had to link, you had to navigate in order to make these systems work. And so what our fishbone analysis showed us was that patients were presenting late. Primary care wasn't necessarily recognizing the cancers when they were still early, and that created delays. The pathways for referral were not working. Diagnostic services need to be set up, creating these health systems delays that needed to be reduced to meet our limitations, and recognizing the inadequacy of funding. So if now we have these 3 pillars, and we have a conceptual idea about what we should be doing, how are you actually going to implement it? And this is for those of us who are clinicians, we tend to have a somewhat myopic view of how systems work because we think of our systems, the care delivery, as the key point. But it is a collaboration between us in the clinical workforce, civil society, that's the driver of this, and government policymakers. And so it's this partnership that we work together in. And when we look at both health system strengthening approaches and partnership approaches to really try to address this in a comprehensive way, and that's where WHO fits. And the messaging here is we're not thinking in silos. We're not thinking narrowly about our interventions. We're thinking broadly, and that means that it's not just breast cancer, but it's the same infrastructure that we use for breast cancer that works for other solid tumors. Indeed, it's the same chronic care infrastructure that you need for other non-communicable diseases. So we're using breast cancer as a tool for health system strengthening. That's the fundamental concept. We're working with CCAN and WHO. We developed this methodology for developing global breast cancer action plans that are specific to city environments where it's manageable. We can see what's actually happening with patient flow. And we use this as a model for establishing breast cancer approaches and guidelines that can be scaled up with fidelity to the national level. And this partnership was how we addressed it. One of the very early meetings we held as an example, this was in Tbilisi, Georgia. We held a meeting where we brought together policymakers and the clinical community and identified low-hanging fruit. They recognized that mammographic screening was not the first question, clinical diagnosis and downstaging those cancers, that was a key issue. And that they had to fund diagnostics. They had funding for treatment, but not funding for diagnostics. It had to be pointed out that the systems won't work if people have to pay out of pocket every time they need a diagnostic workup. And also the access to medicines. By bringing together policymakers and clinicians, that in collaboration, they can come up with real world solutions. One of the solutions I want to mention briefly before we close out is patient navigation, because we started this work in the 90s and we had a lot of ideas and biases about what was really important. And there were certain areas that we kept coming back to and finding, no, you can't bypass this. Education is one of those tools. The public needs to understand what cancer is, what's early detection, and why in the world would I participate in this? And you have to educate the providers. But another fundamental tool is navigation. We saw this example from Kumasi about how do we route patients through these systems. We identified when we did back in the Breast Health Global Initiative, patient navigation was a fundamental need as was identified by our global experts. And they can go at these different levels. And the data was showing us that by using navigation, we could improve screening, we could improve adherence to treatment protocols, and they were associated with better patient satisfaction. This is why the World Health Organization, after I had left and was working in collaboration with WHO published this guide for patient navigation and to provide guidance to countries on what does navigation look like, what are the resources that are needed based upon the 3 pillars. We need to look at monitoring and evaluation techniques and to project outcomes based upon these examples. So in Colombia, Cali, Colombia, this analysis was done on needs for the healthcare systems. They were identifying the gaps that we see in countries throughout Latin America, throughout sub-Saharan Africa, noting these major delays in wait times. And what they found was they predicted that using navigation, they could make major differences. They actually did this intervention in Cali. And what you can see is the difference with between historic controls and the intervention group based upon that introduction of navigation. So we as clinicians might not think the patient navigator is so important. No, they're fundamental because they're how our therapies are actually going to be administered. Indeed, this is relevant to the United States. This is not just for low and middle income countries. Here we have a navigation program that was developed at the University of Chicago, where they were navigating patients and looking at their comparisons. And what they found was significant improvements in diagnostics and cancers that were detected. So the rationale for addressing cancer in low and middle income countries is that this can help us identify where our gaps and opportunities are in underserved communities that do not have the access and funding that is most needed in these settings. Another navigation program, this was done in Malaysia, in which it was a combined community and nurse navigation program, historic controls for comparisons. And what they found was that navigation improved time to essentially every element: time to ultrasound, time to biopsy, time to communication, surgical interventions, use of neoadjuvant chemotherapy. It's really very fundamental. In fact, even treatment adherence was improved through navigation. And so these are really fundamental opportunities for us. We now see navigation as this opportunity for improving context-specific healthcare needs in each of the 3 pillars: early detection, prompt diagnosis, treatment to completion. And as such, it validates the concept of using our pillars and our key performance indicators with navigation as one of the tools in our tool kit to make these improvements. But we have to, in the final part of this discussion, we have to impact assessment. As clinicians, we often view ourselves as the patient advocate. And so if a patient needs a medicine, we advocate for getting that medicine for that patient. Then there's a certain blind spot for us as clinicians because we don't look at the overall budgets. We don't recognize what some of these implications are of things that we want to do that we would consider ideal. Because if it's unaffordable or unsustainable, it's not making that long-term improvement that we wanted to see. So in Kenya was really interested in how to improve their approaches. They achieved funding from the World Bank and identified this model based upon the Global Breast Cancer Initiative framework. They realized we need to create demand, they needed to provide the training and establish the services, and then follow up with monitoring and evaluation. What the model shows us is that we can improve in Kenya from the current status where the significant majority of cancers are at stages 3 or 4, that just with early detection over the first 5 years, we can get closer to a 50-50. And whether we're using clinical detection or mammographic detection, that we can see these significant improvements in outcome, that is the goal and desire. But look at the timelines. These are 5 years, 15 years, 40 years. This is an important message to our ministries because breast cancer is not a short-term investment. It is a long-term investment, and the payoff comes down the road, which is the same thing we saw in high-income environments. But by using these models, we can give cost estimates for different programmatic improvements that would then translate into these final outcomes. So in summary then, primary prevention for breast cancer, which includes weight management, alcohol control, and exercise, these should be promoted. Of course they should be promoted. That will affect a certain number of cancers, but it is the minority, perhaps 1 in 4, 1 in 5. And that's why early detection, prompt diagnosis, and treatment remain this essential component. Countries that have reduced their breast cancer mortality have that combination of access to the public and through public cancer centers and or some public-private partnership, and they have adequate financial support because no country where out-of-pocket payment is the fundamental, that we've never seen reduction in mortality in that setting. Screening through clinical breast exam can achieve the stage shifting. We now have evidence from India that shows that clinical detection can improve breast cancer mortality, and that's why it's the right place to start. Patient navigation can reduce the time to diagnosis and treatment and can improve that treatment adherence. And that this long-term strategy of 5 to 15 years, how we bring together early detection, diagnosis, and comprehensive cancer management, this is how we're going to make these improvements long-term. So with that, I want to thank you again for this opportunity to present to you, and I'd be happy to take any questions if there are any that come up.
Well, thank you, Dr. Anderson, for a very comprehensive, provocative, and helpful presentation as we kick off this global breast cancer seminar series. I really appreciate your expertise and your mentorship for me personally over the last 5 years or so. Are there questions from our participants this morning?
I can start us off with a question. Thank you, Dr. Anderson. In Kenya, we've done some co-screening with breast and cervical cancer and clinical breast exam. Have you seen, in all of your work kind of around the world, have you seen other bundling of services that have been effective with breast cancer screening and different entry points into the system?
So, gosh, when we started doing this work and we'd go to these different places, our team, at least the question that I would ask in my own mind, I'd look at the situation and say, now, if I was in Seattle, what would I do? How would I manage this? And so I think one of the strengths of clinicians being involved is that we have a good understanding of the on-the-ground approaches. Prior to the framework, and before the 2017 initiative, WHO really focused on prevention and palliative care and left that middle part of treatment out. And I think largely because they thought this is unaffordable. This is too complicated. And I think one of the things I saw that you had asked, what are the sorts of opportunities? Where have we seen improvements? It often has to do with this coordination of care. So, for example, in Zambia, there's been very good work done in diagnostics, that how to do the diagnostic workup. To surgeons and to radiologists, doing the diagnostic workup is obvious. Of course, you have to do this. But to people that don't routinely do breast diagnostics, it's not always obvious. Sometimes to our medical oncologists, these are processes that they never saw. So identifying diagnostic facilities that can do the basics, that Zambia is a good example of where this has happened. The long-term outcome that we're looking for is survival benefit. But we have to recognize that mortality benefit, that's like winning the World Series. There are a lot of games you need to play before you can get to the World Series, let alone win it. And it's by going step by step in the field, measuring our outcomes that we see this. And I think we're seeing gradual improvements that in these settings today, beginning with measuring those key performance indicators. That's what that 21 Asian country document was about. They were asking, can we even measure these key performance indicators? And I just, knowing, Jennifer, that you're a medical oncologist, one of the really tough questions that I don't think we've yet addressed adequately is, how can we easily identify treatment completion, distinguishing treatment completion from and abandonment, distinguishing that from, no, we're going to stop the therapy because it's too toxic, and we're not the clinical decision making. So step by step, and I'm really looking forward to seeing what happens in Honduras and seeing how this fits together, because it's so valuable and important.
We do have a question from the chat from Dr. Tarbia. 100% agree with navigation having an impact, but how do we incorporate that into a low and middle income country where nursing schools teach the bare minimum? Navigation, I've seen, relies heavily on nurse coordinators or nurse navigators. Thank you, Tarbia.
It's a great question, and it gets to the point that navigation is not just one thing. Navigation is a concept and a process, but navigating someone through an early detection strategy of getting women that have lumps to come in for diagnostic workups, that is a different navigation need than navigation through treatment, where nursing, some understanding of the processes is really essential to what we do. But I think and that's why WHO published that document that I showed, which is available online, where they're characterizing what navigation programs look like. I think what I would say to trying to answer that question directly is, we don't begin from a top-down approach. We begin from a grassroots approach. And that was the strength of doing work in cities, where you can see, where is my gap actually, and what kind of navigation need would I use in this setting? Is this something that survivors in my clinic can do? And by carefully evaluating, and you build it piece by piece in the same way that you would if you were in Minneapolis and trying to address the underserved communities that you are faced with there. It's not a different process. It is the same process, but adapted to context.
Thank you. Maybe we'll take a couple more questions since we started late. Thank you for this presentation. A big gap in diagnosis in Uganda is access to pathology services. Ben, any comments on pathology services? I know you know it's dear to your heart, but any comments there?
Pathology, when we went to Ghana in 2004 and learned that one pathologist for the 1,000-bed hospital, the reason that was true was because surgical pathology was not a big issue in Africa, where we're thinking about trauma and other chronic diseases. And so it was pathology was underdeveloped because the need had not yet been identified. And so sorting out, do I have quality pathology? Can I measure the tumor markers, ERP or HER2/neu, to determine therapeutic outcomes? These are fundamental drivers. That Ghana story had a happy ending, has a happy ending, which is that while we identified this gap back in 2004, and we used it as the basis, that pathology gap, as an argument for resource stratification, the colleagues that were there in Ghana received training from colleagues in Norway. And now there is a training program in Kumasi, Ghana for pathology. So that the pathology services are essential, and identifying how to make systematic improvements, especially focused on education and training. I think this is where the collaborative opportunities lie.
Very good. We're going to take one more question. I think it's a very interesting one and wasn't addressed today. And this is from Dr. Malik. Women in reproductive age are scarred of mutilation surgery to breast. Breast reconstruction is not well developed in district hospitals. Do you have comments, Ben, about breast reconstruction and being able to offer that to perhaps decrease that preclinical delays that you've talked about?
The point about the social impact of mastectomy cannot be overstated. It is really important. And it's not just a self-image issue. One of the things that we learned in Ghana was that it was very common. It was kind of a shock. It was a shock when we would go and we'd visit these different centers throughout the country, and people would say, well, you know, if she's diagnosed with breast cancer, her husband will probably divorce her. And it was said in this very matter of fact, and the issue was that if cancer's in the family, maybe there's something wrong with the family, and we don't want our son marrying their daughter. Those type of social obstacles are well understood within the country, but can be mysterious to those of us on the outside. And so improving with body image and those physical outcomes makes a difference. When you have late stage presentation, it's difficult to do breast conservation, but if we can downstage disease and improve the breast conservation rates, that is one method by which we can achieve the outcome that was desired. But what about breast reconstruction? Whether we're doing implants or tissue reconstructions, depending on the environment and the affordability, these are very important questions that need to be addressed. But gosh, you know, that there are also complications that go along with this as well. So I think thinking in parallel about what are the pieces that we need to do to create a holistic, patient-centric model, I would say is really key. And I guess, Todd, I'd make one final comment, which is I was so fortunate in this career to be able to go and see and visit and learn. I think a key principle for those of us coming from the high-income country environment, we might be experts from the perspective of how cancer care can go, but we are not experts in terms of how care delivery works in these limited resource environments. So when I would go to visit, I would go as a student, not as an expert. Because if you go as a student and learn, how do you manage this here? What are the ways in which you've done this? That's how we can pull ourselves up by our own bootstraps.
I think that's a great way to end. Thank you, Ben. I think humility is a great global health concept. Thank you again for your time. I know it was very early. It was 5 a.m. when you started this in Seattle. So we really appreciate you coming out of retirement, kind of like Brady did, and becoming the GOAT of global breast cancer.
Yeah. That is the only time that anyone will draw an analogy between me and Tom Brady. So, but Thank you very much. That's a nice compliment.
That's very good. I want to
Good.
just before we close, introduce, talk about our next meeting, which will be on June 3rd. It's going to be focused on high risk breast cancer. There'll be two presentations. Dr. Peter Beich will be talking about genetics, and Dr. Aaron Burke will be talking about risk reduction strategies. So, as Dr. Morgan mentioned in the chat, we are very open to creating this seminar to meet your needs. And so leave us recommendations. You can email us directly, and we look forward to our future meetings. So good morning, good afternoon, and good night. Thank you for participating. Thanks again to Dr. Anderson.